welcome everybody. My name is Edith Atwerebour. I'm a current student at Sarah Lawrence College for genetic counseling. This is a part of the mock genetic counseling series with DNA Today. I'm playing Denise. She's 34 years old. She's an elementary school teacher. She's pregnant right now for about 12 weeks, and she just had some concerns about medications that she was taking and how that would affect the pregnancy. And I had an appointment with lovely Sharon here, who is the genetic counselor. Sharon?
Thank you, Edith, or Denise. I'm Sharon Voyer Lavigne. I'm a licensed genetic counselor, and I specialize in teratology. And I've been doing this for many years, and I'm also a Sarah Lawrence graduate. I'm the coordinator of a program called Mother to Baby, and we're Mother to Baby Connecticut, but this is nationwide, and we're a free service where individuals can call, text, chat, or email and get information about exposures when they're planning a pregnancy, when they're pregnant, or when they're breastfeeding. And, the patient or the provider can reach out to us at any time, and we're happy to provide whatever the most current reproductive data is. So that's what we were doing today with Denise. Thank you. Good morning, Denise.
Good morning.
Thanks for coming. My name is Sharon Voyer Lavigne. I'm the genetic counselor, and we're going to talk about some things today that your doctor asked us to cover.
Okay.
Do you have any questions that you wanted to ask before we got started, or do you want me just to kind of jump right in?
Yeah, so I'm really glad to meet with you today. I just had some concerns about some of the medications I've been taking. This is my second pregnancy. I have a 4-year-old girl. So I just want to make sure that I got the information right before moving forward and make sure there's no effects to the baby.
Okay, wonderful. Okay. Let me cover what I have taken from your medical record, and let's make sure I have everything down correctly.
Okay.
The first medication I have is Ozempic, and you were on the 1.0 milligrams.
Yes.
And that was an injectable. And when did you start taking that?
So I started taking that a year before my second pregnancy. My doctor just looked at my blood sugar, said it was spiking a little bit higher. They noticed it this time, so they wanted to try me on the Ozempic.
So you've been about a year.
Yeah.
And that was for blood sugar control. And then when was the last time you used it?
My last dose was at 7 weeks.
7 weeks.
Yes.
And was that 7 weeks from the first day of your last menstrual period?
Yes.
Okay. Okay. And in the time that you had been on it, had you lost weight?
A little bit. It was just a side effect that wasn't the main goal of why I was taking it, but it was just, just kind of happened that way. So I did lose a little bit of weight.
What's a little bit of weight?
I'll say like maybe 15 pounds.
Okay.
10, 15 pounds.
Okay. And are you still losing weight now?
No.
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 Okay. Good. All right. And then the second medication I have here is Zoloft, and that was 100 milligrams a day?
Yes.
And what were you using that for?
For my depression.
Okay. And is it working well?
Yes.
All right. And how long have you been on that?
So I've been on that since I graduated college. So
Okay.
a few years ago. It's been helpful ever since. I did use it during my first pregnancy. At the time, it was reduced to about 50 milligrams instead of the 100.
Okay.
And that worked pretty well.
Oh, you did well on the lower dose then. Yeah. Okay. All right. But 100 seems to be working well for you now?
Yeah, that seems to be working for me.
All right. And then you also have a Xanax 0.25, and you use that as needed. Is that correct?
Yes. At times I do have just small little panic attacks every once in a while. More sporadic, really. So I just take it as I need to.
Okay. And how often do you think that is? Once a week, twice a week, once a month?
Let's say like maybe once a month.
Okay.
Maybe once a month to once every other month. Yeah.
All right. And since you've been pregnant, has that increased or decreased?
It stayed about the same. I think so far since this pregnancy, I've taken Zol once.
Okay.
Yeah.
All right. And do you feel that you're trying not to take it, or you're taking it when you need it?
Honestly, I'm trying not to take it.
Okay.
Yeah.
Okay.
I'm trying not to. Been reaching out to like family, like for extra support, my therapist, because I was just kind of concerned about the pregnancy. I didn't want to like do anything.
Right. Sure.
That would be negative effects. Yeah.
Okay. All right. And then since you're off the Ozempic now, what has been the alternative for that to treat the blood sugar?
So now I've been put on Metformin.
Okay.
Actually. Yeah.
Do you know what dose you're currently on?
I believe it's 2 milligrams.
Okay. It's probably 2,000 milligrams.
Okay.
But that's okay. And how are your blood sugars?
So right now, I think it's about 7.5.
Okay. Okay. All right. And is that about what it was when you were on the Ozempic, or was it better or worse?
It's about the same. Yeah, it's about the same.
Okay. Okay. And who prescribed the metformin?
So this is my general physician.
Okay.
Yeah.
Does the OB know about all the medications?
My OB does know. I think that when I go back to my OB, I'm gonna like let her know the update for the change in medication from my general physician.
Okay. All right. Good. Because they're going to want to know everything that you're on, so that they can take care of you the best way they can. Okay, well, this is really what I was prepared to discuss today, so I'm going to give you a little bit of background first off, and that is that every time someone gets pregnant, there's a chance you could have a baby with a birth defect. That's me, that's you, it's our mothers, our grandmothers. And that background risk is about 3%. So that means out of 100 babies born, we would only expect about 3 to be born with a birth defect. Okay? And what I do then is I look at your particular exposures, and I pay attention to when you started or stopped, or where in the pregnancy are you using them, and then I to help me better understand whether you're at any different risk than the background rate. Okay. So that's the first thing you have to keep in mind, is it's never a guarantee to have a perfect baby, and you've had a child before, so I'm sure you already knew that. The second issue is timing. And so we look at when medications are used, because during the course of a pregnancy, in the first trimester, the first 12 or 14 weeks or so, that's when all the organs are forming. And so that if something's going to interfere with how those organs are created, then that's the time that we're going to look most closely at. Later on in pregnancy, we're looking for things like, can it affect the baby's growth? Can it, the brain is still forming, can it have any effects on brain? And is it potentially going to lead to premature delivery or low birth weight? So we're looking at those things later on in pregnancy. So for you, the Zoloft is going to be used throughout the pregnancy. So we're going to talk about all times in the pregnancy for what we consider a concern or not a concern for Zoloft. And then the Ozempic was stopped early, so we're going to talk about why that matters. And then the Xanax is really sporadic and intermittent, and we'll talk a little bit more about that. And now, and of course, the metformin from, did you start right around 7 weeks? Or?
Around 7 weeks,
okay.
Yes.
All right, so we're going to talk about that as well.
Okay.
All right. So is there one that you're really worried about that you wanted me to start with first?
Probably the metformin and the Ozempic, like
the two.
Yes.
Okay. So Ozempic is one of the newer medications on the market. So there's not a lot of human data yet for us to really look at. What's important to understand about that medication is it's a very large molecule, meaning it may or may not be crossing the placenta in the same way that smaller molecule medications could. And you stopped at 7 weeks, so you're still in that period when all the organs are forming. But this medication also can linger in the body for weeks.
Really?
Yes. So every day that goes by, there's a little bit less of the medication in your system, but you still have some residual medication there for a period of time. There has not been enough information yet for us to say for certain that this is going to impact your background risk for birth defects.
Okay.
The concern is, I would say, more for keeping your blood sugar in check.
Yes.
Because if your blood sugars are spiking high and low, or high a lot, that in itself can increase the chances for birth defects.
Okay.
So that you mentioned your number was around 7.5 for
Yes.
that's your A1C number.
Mm-hmm.
The higher that number goes, the greater the risk there is for birth defects.
Okay.
And the birth defects that we see in uncontrolled diabetes, they can be significant and vary from heart defects to spinal problems to all different kinds of things. So again, the 7 number is not in the high danger zone that we would be very concerned about, but we would want you to be trending lower and not to be continuing to increase. So the metformin is designed to help with that, but it doesn't give you as good a tight control on your blood sugar as some other treatments would.
Okay.
And the treatment I'm referring to, and I'm sure you heard, is insulin.
Okay, yes.
Is the drug of choice in pregnancy to keep you as in best control as possible.
Okay.
And so I think you should, have that conversation with your obstetrician. And there are people called diabetes nurse educators that can actually be someone that you can consult with, that can walk you through the process of how you're going to learn, if your OB decides insulin is the best for you, how to walk through that whole process.
Okay.
It may feel overwhelming, it may feel complicated, but I think the consult with the diabetes nurse educator is going to help you take things one step at a time. Okay. And let your obstetrician be the best person to decide whether you're the best candidate for that or whether they're going to keep you on the metformin for a period of time. Okay. Have you been having side effects at all with the metformin?
No, not recently.
Okay, good. So Ozempic is probably not going to be a medication they're going to put you back on right now. They may revisit that after you've had this baby. Okay. And at that point, decide whether the Ozempic is worth another try. Maybe there are different medications available at that time, or there's something that might work better for you specifically. And I think they'll assess that at that time.
Okay, that sounds good. Yeah.
Right. So I think at this point, we can't really say that that's a high risk exposure. Okay. So that's good.
Yeah, that makes me feel a whole lot better.
Okay,
yeah.
Good. Okay. Now the Zoloft, you use that to treat depression.
Yes.
And we know that untreated depression, anxiety, and pregnancy can lead to pregnancy complications. So typically, we're always looking at risk versus benefit. If you don't take the medication, what will your symptoms be like, and how would those impact your pregnancy? Right? So if you decide, I don't want to take anything in pregnancy, and you come off of that medication and your depression symptoms return, depression is different for everybody. So what would your symptoms be like for depression?
More withdrawn, just more isolation, not really interacting with my family as much. So for some people, it could affect their sleep, it can affect their eating patterns, it could affect, like you said, their interactions with their family. All of those things are important, and we can't have a healthy baby if we don't have a healthy mom. So this happens to be one of the medications used to treat depression that was very popular when it first came out. So that's good for us, because that means there's a lot of data. That means a lot of women of childbearing age took the medication, and we collected that data. And the vast majority of data on this particular product, the Zoloft, does not suggest any significant increased risk for structural birth defects. Okay, that's good.
We go back to the concern about, is there prematurity that could be an issue, low birth weight, all those things you're going to get followed for anyways in pregnancy. Typically here, what we do is you have what's called an anatomy scan, which we do at around between 18 and 20 weeks or so, and that's when they go head to toe and look at all the body parts. So they look, is everything where it's supposed to be? Does everything appear to be formed in the way that it should be? It's not a guarantee that everything is perfect. You know, we can see the structures inside the skull, the brain, but we can't be certain that they're functioning properly. But we can't be sure of that for anybody. Right? So we looked for as much as we can. We look at the heart, we look at the kidneys, we look at the bladder, emptying and filling, to see, is there anything that appears to be out of the ordinary? And Zoloft is not something that we would expect there to be a high risk for anything. There were some questions about whether this medication you might have heard is called an SSRI, selective serotonin reuptake inhibitor. And those medications had some question when they first came out as to whether or not they could cause heart defects. And the bottom line is the bulk of the literature doesn't support that. And heart defects are one of the most common birth defects in man anyways. So it may be difficult to tease out how much is just by chance alone and how much does the medication change that. And I think when we do that anatomy scan, we're looking at the heart. And for you, they might also offer you what's called a fetal echocardiogram, which is just a fancy way of saying a special ultrasound of the baby's heart. And in that ultrasound, they look at all the vessels coming into the heart, all the vessels leaving the heart, the chambers, the walls between it. So they're really getting a detailed ultrasound. Does the heart look like it's formed properly? Okay. So I think it's fairly routine for someone who's been on an SSRI for us to add a little bit of reassurance by doing that ultrasound. Ultrasounds are not invasive. They don't pose any risk to the pregnancy, and they give us a little bit more information. Okay. And we usually don't do that one until about 21, 22 weeks. So you have the anatomy scan first.
So I have some time before then.
Yes.
Yes. Sounds good.
The Xanax, you're taking it really sporadically. In general, it's not expected to be a high-risk product either. But I think, it is a drug that you can get dependent upon. So it is something that using it every day may not be the best idea unless that's what you need. And if that's what you're finding, that you're feeling you're needing it more, then you're actually taking it. That we need to go back to the person who prescribes it and have a discussion over, is this the best choice? Is there something else we can do differently? Your metabolism changes in pregnancy, so how you break down your medications a lot of times changes your need for them. So sometimes you need more when you're pregnant than when you're not, because you're clearing it from your body faster.
I didn't realize that.
And also, as you get further along in pregnancy, you're getting bigger and your blood volume is really increasing. So the medications are more diluted and you need more. So even, perhaps with the Zoloft, if you start to feel like your symptoms are coming back, then we need to have a conversation with the doctor that prescribes them about whether we need to tweak the dose or whether something else is going on. So you mentioned that you are you in talk therapy now?
Yes, I am.
Okay. So that's great, because it's nice to have another person eyeballing you while you're pregnant, because I think we're the last person to acknowledge that maybe we're having some struggles, right? So people around us that we need to trust to come to us and say, you're just not yourself. And so does your partner know what you're like when you're struggling?
He does, and he gets kind of worried, like if he sees any triggering signals that may may be happening.
Okay, good. Yeah. So promise me that if he comes to you and he says, Denise, this isn't what you're usually like in these situations, to not all of a sudden say, well, of course, I'm creating life and this is hard and all this other stuff. Yes. Say, okay, let's let the doctors decide whether this is something related to the depression and I need a medication tweak, or this is something pregnancy related and we need, the OB to chime in on it. So let the doctors make the decision. And that way we're not going to miss an opportunity to keep you well.
Okay.
Right? Later on in pregnancy, you may find that, your symptoms start to creep back in, and that can happen even on medication. So it's good to be in talk therapy, because that's another non-medicine way to try to keep the symptoms at bay. Okay. So your therapist may have tricks to sort of make things go a little bit more smoothly.
Okay.
You have a child at home this time.
Yes.
So you can't just come home from a busy day with all your kids in the classroom and tune out the world, because you're on 24/7 when you're a mom, right? So there may be other strategies in terms of maybe getting some other help or some babysitting help or whatever, trading off with your partner for some alone time, just to help you get over the hump through the pregnancy. At the end, if you're not taking the Xanax every day, then we're not really going to be considering that the Xanax may have some issues with the baby adapting to his or her environment without being exposed. Okay. So it's kind of a withdrawal type symptom. Okay. And no mother wants their baby to go through that, I understand. But if you're not using, and so you may read about this, so I'm telling you, if you're not using it on a regular basis, that's not really going to be an issue for the baby. The Zoloft, on the other hand, can also have some of those symptoms occur. The issue is we know how to take care of them. Okay. And if in some cases there's nothing that needs to be done. And you may not even notice the baby's a little bit fussier, or the baby's got, not sleeping well or whatever. You may not notice that is different. You do have another child, so you have somebody to compare to, but every child is different, so try not to do that. But you will be an experienced mother this time, so you may notice things. And so the best thing would be to share any concerns you have with your child's provider. Okay. To see what they have to say. And I'm assuming that since you have a child already, that you already have a pediatrician or a care provider for your child.
Yes.
So it wouldn't be a bad idea to have a conversation with them about what meds are you on in this pregnancy, and how do they feel about that, so you have an idea of how they might be reacting once you give birth.
Okay. I can do that.
Okay. Again, I don't think that either of those are going to pose a high risk in the newborn period for the baby needing any extra care. You will be delivering here at this facility, so we do have the capabilities that should the baby need any neonatal care, we have that unit here as well. Oh, great. So it's better to prepare, but it's probably unlikely that you're going to need that. Okay. All right. So I just dumped a whole lot of information on you. Did you have any questions about the Zoloft or the Xanax?
No, this was great. Definitely more information for me. And it's such a relief to realize, that is, well studied. The Zoloft, we have more data than the Ozempic for sure. So I'm feeling really much better about it.
The bottom line for all of the exposures is I don't think you're at any significantly greater risk than you would have been without these. I think keeping the diabetes in check is our primary concern, because that poses potential risk. I think being with a therapist is a great idea. If you feel, how often are you seeing them? Once a week, once a month?
By twice a month.
Okay. So if you feel like it, you could increase that. If you feel like you need some more support, that would always be a good way to go. We also have supports here in our facility.
Oh, great.
We have some home visitation people that could come, that could meet with you ahead of time,
That'd be so
meet
helpful.
with you after. just to provide some added supports. I always joke that I think everybody should get that, but there are not enough of them, and there are too many people having babies for us to provide all of that support. But I think I just want you to know that those other supports are available should you need them. So I want you to feel comfortable speaking out if you need to. Okay. There's a lot of things that we could do, switch up, switch around, to help get you through. And then in the postpartum period, there is a chance that you could have a resurgence of your depression or anxiety. They could get worse. You know, you've got a new baby, you're struggling, your body's recovering as it is, you've got a new infant, and you have a child at home now too. So you've got a lot going on. And so it may be that, again, your meds would be very important. Some women feel like, well, then I don't want the baby to have the risk of any withdrawal symptoms, so I'm going to wean off my meds before I give birth. The problem with that is you're still going to be needing your medication. And at that period in the pregnancy is probably one of the most stressful periods when you're getting ready to have the baby. And then in the newborn period, after you deliver, you don't just pop a pill and feel better. It takes a period of time for the medicine to work into your system and for you to feel the benefits of it. So again, that's not usually a recommendation. Okay. Keeping you stable, keeping you well is our goal, and the benefits outweigh potential risks with the medications that you're using.
So I should definitely talk to my provider before doing anything on my own with my...
Absolutely. You don't want to start, you don't want to... I know you said you took 50 milligrams last pregnancy. I wouldn't do that without the consulting both the OB and the PCP to see if that's really a viable option for you.
I can do that,
I don't have dose information, so I can't tell you that 50 is better than 100. The best meds for you are the ones that work for you, and the best dose is the dose that works for you. So I'm going with what you're on now because you're saying that you're doing well on these. It sounds like you might need the Xanax more than you're taking it. So have that conversation with them about how they feel about that. And whether they think that product is the best product for you to use for whatever symptoms you're having.
That sounds good.
All right. So I think you have a couple of homework assignments, I suppose, is to talk to the OB about the, maybe consulting with somebody about the diabetes and how to manage that for the remainder of the pregnancy. And, keeping up with the therapist and keeping in touch with the person who prescribes your psych meds about what is the best regimen for you in this pregnancy.
That sounds doable.
All right. And then try to stay away from sick kids at school.
I'll try. Now they're on the grand summer break, so
you have a break and then they come back. So I don't know, classrooms nowadays probably have the hand sanitizers everywhere, and we're washing our hands a lot more. I saw from your record you're up to date on all your vaccines, so that definitely is a protective effect for you. But I just keep that in mind, that you're protecting yourself, but you're also protecting the baby. If you get sick with something, we can take care of you, but sometimes the meds that we would use to take care of you are not things that we would want to use in a pregnancy. So stay as well as you possibly can. I know that's hard.
I'll definitely will.
All right. Do you have any questions for me?
No, this was great. You answered all my questions, my major concerns, so I feel better moving forward.
Excellent. So you have the ability now to reach back out to me should your meds change, should you have other questions. If you feel comfortable going home and sharing this information with your partner,
Yes.
Yes? Okay. So if your partner has questions, you can call me and we can go through those on the phone.
Sounds good.
Your providers are going to get a note. They're going to get a letter. So they're going to have all the information. It's going to go into your chart. So the next person that you see or takes care of you can see what we've already discussed. Okay. But I want the communication to be open. So should you have any other questions or concerns, just to pick up the phone and give us a ring.
Okay.
Okay.
Thank you so much, Sharon.
You're very welcome. It's nice to see you today, and good luck on the rest of your pregnancy.
Thank you.
Take care.
You too.
All right.
That's a wrap on this episode of DNA Today. To keep exploring the world of genetics and genomics with us, head to DNAtoday.com for hundreds of episodes, show notes, and resources from our archive dating back to 2012. DNA Today is part of Genepool Media, the Science Podcast Network. To check out more of our episodes, visit genepoolmedia.com. For questions, guest pitches, or sponsorship inquiries, email info@dnatoday.com. And if you enjoyed this episode, a rating or review on Apple Podcasts or Spotify helps more people find the show. Thanks for joining us. I'm Denise, and I'll be back next week to continue discovering new advances in the world of genetics.